was the treatment done earlier for that. We are using a single bone fracture. What do you mean by femoral graft? No. What types of grafting you know? Bone graft. Types of grafting. You know the basics of it.
So, femoral graft is placed subperiosteally, especially posteriorly. Posterior, distal 1/3 of the tibia will have poor vascularity compared to the osteoperiosteial flap.
Without doing any
Disturbance.
to the fracture site problem. This is the fibrous region.
And you have placed the graft posteriorly, not anterior medially. That's important.
It is called osteoperiosteial flap.
Osteoperiosteial flap only.
With implant in situ and 2 years old ILN for right femurs. Complaint of pain and swelling since 1 week in the lateral aspect of right knee joint.
It is an infected implant? Is it an infected implant? Is it a infected implant?
Sir, the plate is not infected, sir. It's still in. And yes, yes, sir. Yes,
So there is a sinus tract is there,
yes,
and
sir.
sinus tract is communicating.
Yes,
Yeah,
with the plate.
communicating. Kada. Yeah, that is important point. Yes, sir.
CT sinogram is done. To know the communication, whether it is communicated with the bone, any abscess or cavities, joint also. So within implant removal, sent tissue for culture and sensitivity.
On table ROM is good.
Yes.
90, 110, 120. How much?
Before also there is no problem in ROM, sir.
No, no. Before, after.
Both normal.
Before how much?
It is normal. It's 110 degree. 110 degree work on the sir before good. We checked it. Yes, yes, sir. Yes. Yes, sir. Yesterday only it was. Yes, sir. Yes, sir. There's no history of
2
trauma
years
there,
old.
sir.
2 years old implant. 2 years old implant.
Yes, sir. Yes, only, sir. It has united well, sir. There's no. Didn't keep here, sir. We have it.
So Dr. Saab, so this patient, see, Dr. Saab, this patient went to OT. This patient went to OT. The patient is under anesthesia. You have to check it under anesthesia. That is a better. So it is a better improvement in ROM. Yes. Ante adi cheppali. No, that is 2 years old. That is 2 years old. No, not at one time. Ade naaku first opinion. Not at one time. That is 6 years. This is 8 months.
Good morning,
2
sir.
years. 2 years. 2 years. 8 months.
These are the cases done in Unit 3. 90-year female with intertrochanteric fracture of right femur, which is reverse oblique type, and 3 months post-op case of intertrochanteric fracture of left femur with implant in situ. We have done close reduction with long PFN for right femur. Simple, sir. Communication is there. Combination. Yes, sir.
So what is the quality of bone?
Porotic ఉంది, sir.
Osteoporotic,
90 years, sir.
అదే 90 అదే అక్కడ గొల్లెమా. So that is also important. The age of the patient, hello Maharaj,
Sir.
the age of the patient, the quality of the bone also plays a great role in fracture union. Am I right? I don't know.
70-year
90
female
years
with
old
intracapsular
female
fracture
with
neck of
osteoporotic bone, it is good for fracture union or bad for fracture union, or this is a risk factor, not a risk factor. It is చెప్పాలి. మాస్క్ వేసుకోండి, ఎట్లా మాస్క్ తీయన్నా. ఏం సార్ అందరికీ సూపర్ రజనీకాంత్ దగ్గర పంపించాలి నేను.
70-year female with intracapsular fracture neck of left femur with 1 year 8 month post-op case of closed distal third shaft fracture of left femur with implant in situ. We have done implant removal. She fell down again, sir. No, sir. She fell down. Fresh injury, sir. Yes, sir. Yes, sir. Only recent trauma, sir. 2 days back. Yes, sir. 1 year 8 months, sir. Yes, sir. Yeah, recently, sir. Slip and fall, sir. Yes, sir. Yeah, pelvis with both hip. Yes, sir. Yes, sir. Okay, sir. Okay, sir. We have done implant removal and bipolar cemented hemiarthroplasty for left hip. So 22-year-old male with close proximal third both bone shaft fracture of left forearm. Sir. Yes, sir. Close both bone shaft. Yeah. Close both bone shaft fracture of left leg, sir. Second is a close proximal both bone shaft fracture of proximal radius and ulna. With yes, sir, ipsilateral, same side, sir. And third is a proximal phalanx of second and third of left hand, sir. Same side, sir. We have done CRF with island for left tibia, ORF with plating for both radius and ulna, and external fixator for left metacarpals. So, CRF with island, sir. Yes, sir. Will unite, sir. Sir, plating, sir. Both radius and ulna.
So this is the intraoptic, sir. Yeah.
Intraoptic, sir. Yes, sir. Yeah. Sir? No, no, sir. No, sir. Ulna is communicated. Sir. Sir, ulna, sir. Ulna. So butterfly fragment is there, sir. For ulna.
What approach you have gone for radius?
Thompson, sir. Thompson approach.
Did you identify pin?
Yes, sir. So.
So now the pin is over the plate now.
Yes, sir. Over the plate.
So what happens over here? You get injured, no?
Finger.
No.
It won't
So we have kind of process.
No,
You release completely the arcade or not?
completely we expose, sir.
You zoom in to see. In what muscle you have found this?
Supinator, no, sir.
Simulator?
Yes, sir.
Does it have two heads or not? Only one head.
Sir.
Supinator. Where is the arch of process? Okay, what plate is this?
DCP, sir. Small DCP.
All this.
Yes, sir.
So it is ideal to keep here. After one foot of radius. Is it tubular or semi-tubular? Semi-tubular we have for this. Semi-tubular idea for the upper one foot of radius. Nice, it has complete fragment there. There is no compression yet. Directly can switch it again. There is space in that. That is semi-tubular plate.
Okay, sir.
One foot tubular plate. But only important thing here is this row. Pin is important here.
Yes, sir.
Right.
So you have put it 2 drains or 1 drain?
One drain, sir.
1 drain. Go back. How many drains are there? 1 or 2?
One, sir. Only
Why
one
the
drain.
drain? Why do you kept the drain?
Prevent
Huh? Go on,
To prevent
compartment.
Go to the mask, go to the mic, clear loudly. Meant for all, madam. Send not for all, not for you and me.
to prevent the compartments.
Why compartment syndrome?
Pressure in the
Pressure.
valve.
Due to
You increase the compartment side by using the plate and screws. That is a bone fracture.
You could close the wound properly, no?
yes. Yes, sir.
Do this we made. Did you close it?
Yes,
I
sir.
know, no.
Yes, sir.
Without any gap.
Without any.
So,
It's not there in this.
no.
We have.
Suppose you are unable to close the wound. Which
We
one you
can
want?
radius side we can leave
Leave. Right?
because it will approximate. We will
So
heal.
the first plate, what is it? Which subcutaneous bone?
Yes, sir.
Subcutaneous is ulnar,
Radius
sir.
is covered muscle.
yes,
Just
sir.
plate promoter. So what type of, suture you want to do? Suppose it's unable to close properly. It's called shoestring suturing, that's all. That's what you do.
You should not suture the deep fascia. Why you should not suture the deep fascia?
Increase
Pressure.
So the deep fascia is a unyielding, inelastic structure.
Next.
It will aggravate the phenomena of compartment syndrome.
Right.
63-year female.
Facial compartment, osteofacial.
Yes.
Forearm compartments are osteofacial. And go back, sir. Last one more point. So, yeah.
Because you don't know how to apply the tension switches. Like what Narayana described, what will
So what about the hand? What fixator is called?
wait, let one person be finished.
Yes, sir. Yes. Please, sir. Please, sir.
You do not know how to put the tension switches. What do you do then? You just try to approximate the wound as closely as possible with muzzle layer, and if you use subcutaneous switches so that the implant doesn't get exposed, and wait for 72 hours, by which time after elevation and active movement the edema will subside and you do what is called as a delayed primary closure. What is the difference between delayed primary closure and secondary switches?
injection.
A secondary suture later on we will do some.
Getting
Infected, yes.
debridement and then closing the wound is
Secondary suturing.
this is primary closure. Delayed.
Delayed primary closure.
Mini fixator. This is
Okay, sir.
Hand is
Yes, yes, sir.
the minifixators
Ante,
separate
ante.
ఉంటాయి. They are available for the metacarpals and for the metatarsals also, the minifixators. There is a workshop training on minifixators. Hand surgery, it is there.
63-year
minifixators.
female with closed proximal third shaft fracture of left femur, sir. We have done closed reduction with long PFN for the left femur. We have tried docking, sir, in this, but oblique ఉంది, sir. Yes. Slip and fall, sir. Slip and fall. '63, sir. So if
One second.
we don't
By
achieve
looking-
compression,
one
we'll
second,
try
sir, one second.
dynamizations.
So when you say it is pathological fractures, the pathological fractures are transverse or oblique?
నేను పెథలాజికల్ అనలే, సార్.
అదే ఉంటే ఏముంటా, నువ్వు అనలేదని కాదు మేము అంటున్నాం. పెథలాజికల్ ఫ్రాక్చర్ కి నార్మల్ ఫ్రాక్చర్, హౌ దే లుక్ లైక్ పెథలాజికల్
ట్రాన్స్ఫర్స్ ఉంటాయి కదా, సార్. ట్రాన్స్ఫర్స్
వై
ఉంటాయి.
ట్రాన్స్ఫర్స్, వై నాట్ ఆబ్లిక్?
ఉండవు, సార్, అట్లా.
ఉండరే. So why transverse fractures are pathological? Most of the pathological fractures are transverse. Traumatic fractures may be spiral, oblique, or comminuted, compound, so on. So why transverse in pathological fractures?
చెప్పండి.
Because there are two groups of trabecular. One is transverse group and is vertical group. In pathological fracture, the transverse group of trabecular pattern will be affected.
In
They are
pathological
weak,
fractures.
so they get fractured. So that's why they are transverse fracture in pathological fracture compared to a traumatic fractures.
Yes.
Reni Swami Ranga.
Sir? No. Yes. Yes, sir, it will cause delayed union. Yes, sir. There is a chance. Dynamizations. We'll remove the static and leave the dynamic screw. Not immediately, sir. We'll wait for some time. We'll start weight bearing and then we'll see. 4 to 6 weeks. Yes.
So usually because there is something called a milky procedure.
I cannot-
Before using the distal interlocking bolt, you have to reduce and then fix it. ఏం చెప్పింది విన్నావా? వినపడలే. నేను వినలే. నువ్వు వద్దులేనా, నువ్వు చెప్పు. నువ్వు వినబాక నాన్న, నువ్వు వింటే కష్టం, నువ్వు వింటే పోతేనే మంచిగా ఉంటుంది. సైలెన్స్ ఇస్ ద బెస్ట్ ఆన్సర్.
Okay.
ఇఫ్ యూ డోంట్ నో ఇస్ సేవ్ సైలెంట్.
Yes.
అందుకే సైలెన్స్ కూడా బెటర్.
Okay, sir.
అంతే కదా?
Ante, sir.
అంతే కాదు.
85-year male with 10 days old intertrochanteric fracture of right femur. We have done closed reduction with PFN for right femur. And then
బాగా చదవాలి. బాగా చదవాలి. నువ్వు మాస్టర్
28-year-old female with
Active
grade
ఉండాలి.
1 compound distal third both bone shaft fracture of left forearm with no distal neurovascular deficit, sir. We have done open reduction and plating for radius and ulna. For radius, Henry's approach, sir, and for subcutaneous, sir. Thanks.
By all practical purposes, the fracture both bones should be treated like intra-articular fractures. क्या फिर दो
आगे आगे विशाल. You can wait, sir. You can wait, sir. Tension band wearing versus pre-contoured plate fixation for two-part and multifragmentary olecranon fracture, sir. This is a journal from Journal of Bone and Joint Surgery done in September 2025 in Norway, sir. Norway. Transfers. English language. No, sir. I don't have notes. This is a copyright. In this, it is a It is a random control trial to compare the outcomes of tension band wiring and pre-contoured plate fixation for treatment of two-part and multifragmentary isolated displaced olecranon fractures. They have taken into consideration only type Mayo classification 2A and 2B, sir. In this study, 200 patients were taken between age 18 to 75 years who has isolated displaced olecranon fractures and allocated randomly into tension band wiring group and plate fixation group, 100 in each. And the patient were followed at 6 weeks, 12 weeks, 12 months and 24 months. And this study was designed as a non-inferiority trial, and the outcome was measured with the help of quick disability of the arm, shoulder and hand score at 12 months.
So what is that study was designed as
Non-inferiority trial, sir. Tension band wiring is not inferior to the plating. They have
What is the time duration that they have taken?
from December 2017 to August 2019 they have taken, sir. 2 years.
So your better functional outcome results are the DBW or plating?
Both it is same. They have said it is same for both.
So then where there is a difference. So there is a specific indication for TBW, it should be like transverse fracture. In transverse fracture, the TBW principles works well. In oblique or multi-fragment comminuted fracture, the TBW never works. That is basic fundamental principle. Then we have to talk about AO classification. You are talking about Mayo classification, am I right?
This they have considered Mayo class.
You are the leading surgeon. ఊర్లో వంటకి టెంకాయలు కలిసి టెంకాయలు కూసుకుపోతావా?
It is not our study.
అదే that's what I said. That's what you are analyzing. That's what you are analyzing. This house is meant for analysis.
Go ahead.
Olecranon fractures are treated operatively when they are displaced, and for simple displaced fracture, tension band wiring is traditionally recommended. However, with increased use of plate fixation, especially for comminuted fractures, uncertainty exists regarding the optimal treatment. So, evidence comparing tension band wiring and plate fixation for Mayo 2A and 2B fracture is limited. This trial aims to address these gaps.
So what is limited? Evidence is limited. To show the type of healing or type of healing.
No, tension band wiring was preferred only for 2A type, sir, not for 2B. 2B were fixed with plating only previously. So,
Evidence for what? Evidence for medium using plate as well as house plate or the other plate.
any plating
TBW.
fixation.
There is no evidence till now. So this is good, this is bad. That's the reason they have to go to that trial.
Trial. It should be extraarticular transfers, and there should be no intraarticular involvement. No combination. But in this, yeah. Material and methods. This is Mayo type classification. Type 1 is undisplaced, stable. A is non-communicated, and B is communicated, undisplaced. In type 2B, type 2 displaced fracture, but these are stable fractures. With type 2A non-communicated, and type 2B is communicated fracture.
Not communicated.
Communicated. Communicated. And type 3 are unstable fractures, non-communicated and communicated.
That was the first question. So you show that it is not inferior.
Inferior. That's it.
And you said both the results are same.
Almost same.
Mari? So the basic fundamental principle you have to talk. So which is the recent classification? Better classification.
AO.
AO class. Why AO is superior to Mayo classification? Better plan of management, better functional
Function.
optimization. The compared to this.
It is a
Completely extraarticular, partial intraarticular, intraarticular. So you are taking intraarticular fracture or extraarticular?
extraarticular.
Extra, all are extraarticular.
Yes.
No intraarticular.
No, sir.
But you said
It is
multifragment
an
community.
intraarticular fracture, all are fracture.
Olecranon fracture.
Extraarticular, అది గోల్డెం. అది point.
Okay, proceed.
Multi-center randomized control trial conducted between December 2017 and August. Okay, sir. Inclusion criteria age 18 to 75 years and displacement more than 2 mm of olecranon fracture. And exclusion criteria include fracture dislocation, non-compliant patients, ipsilateral upper extremity fractures, extension distal to coronoid, and prior reduced elbow function, patients unable to consent, and drug or alcohol abuse, open fractures, and triceps avulsion excluded. In treatment strategy, they have done tension band wiring using two parallel K-wire placed through proximal olecranon and stainless steel wire loop in a figure of 8 anterior to the olecranon, and K-wires were bent and impacted into the bore after tensioning. And for plate fixation, they have placed dorsal placement of pre-contoured locking plate. They use 3 types, and temporary the fracture was reduced with the help of clamps or K-wires, and plate was fixed with a screw according to manufacturer's recommendation. Pre-contoured plates. Pre-contoured. Synthesis, Variax, and Acumade. Yes. And immediately active range of movement was started after subsidence of pain and swelling, and cast was not kept more than 14 days. First 6 weeks only limited weight bearing up to 1 kg was allowed, and only active flexion was advised, and after 6 weeks unrestricted range of movements and activities were advised, and standardized physiotherapy protocol were given. Outcome measures, primary outcome measured by quick dash at 12 months, and secondary outcome measures with myo-elbow performance scaling, satisfaction.
Disability.
Arms, shoulder, and hands. Range. Yes, 9 points. Then the result, tension band wiring is non-inferior to plate at 12 months with mean quick dash of TBW, both TBW and plate fixation was 5, sir. So it met the non-inferiority criteria of a median of difference with 0, sir. Beside 5-degree difference in median elbow flexion arc, no significant differences between both the groups were seen. Yes. Good morning. Good morning, sir. This is my journal. Tension band wiring, sir.
Which is VGC. Very good. I think that's more than what I expected. But name we can't see. Okay, go on. Huh?
Tension band wiring versus pre-contoured plate for 2-part and multifragmentary olecranon fracture, sir. It was done in September 2025, Journal of Bone and Joint Surgery in Norway, from Norway. And it is designed as a non-inferiority trail. Materials are multi-center randomized control trials, sir, taken between December 2017 to August 2020, and it was done in multiple hospitals across Norway. 200 patients were taken into consideration with divided into 2 groups, tension band wiring 100 and plate fixation 100, sir. They were followed up at 6 weeks, 12 weeks, 12 months and 24 months. And injury mechanism, fracture classification, ulnar nerve examination and motor examination were recorded. Inclusion criteria, age 18 to 75 years and displaced fracture more than 2 mm. And exclusion criteria: fracture dislocation, non-compliant patients, ipsilateral upper extremity fractures, extension distal to coronoid, prior reduced elbow function, and patient unable to give consent, drug alcohol abuse, open fractures, and triceps avulsion were excluded. They took 18 to 75 years. 75 years. No, sir, they didn't compare.
No, you did not understand. They included 18 years and 75 years.
Yes.
Function, are they compatible? Probably, Rajshekar, your question is very valid. If both groups contain similar distribution, so it will null the effect of young people.
No, they took the main. No, they did.
match the
No,
group?
sir, did
You-
not.
you-
Yeah, did not match, sir.
How do you know?
They only gave a main age of 55.
You don't know. Probably matching means the other group, two groups should have
Similar.
similar distribution. So it was randomized?
Yes, sir, randomly.
Randomized.
Randomized.
There's good possibility they might have matched.
Treatment strategy: tension band wiring. They used two parallel K wires placed through. Yes.
Okay.
Rehabilitation was started immediately after decrease of pain and swelling. Range of movement started, and cast was removed after 14 days. And the first 6 weeks, limited weight bearing, less than 1 kg was advised. And after 6 weeks, unrestricted range of movements and activities advised. And outcome were measured with quick dash at 12 months. And other outcome measures like myo elbow performance score and pain, range of movement, and radiographic reduction were taken into consideration. And the results were tension band wiring is non-inferior to plate at 12 months with a median quick dash of 5 for both the groups. And thus it met the non-inferiority criteria with a median of difference 0.
So what does it mean?
Tension
Non-inferiority means?
Tension band wiring is not inferior to plating.
Okay.
Functional outcomes, range of movements, it is similar till 12 months. After 12 months, there was a slightly decrease in flexion arcs in tension band wiring group. Other, it was similar. Common complications included hardware irritation and malposition, mostly in cases of tension band wiring, and malpositioned hardware requiring reoperation, more common in tension band wiring. 38% in tension band wiring and 26% in plate fixation. And infection rate were similar in both the groups. Loss of reduction slightly higher in plate fixation, but not statistically significant. This is all the patients. 200 patients were taken into consideration.
What's anything completely dark? Huh? Intentionally made it dark or what?
No, sir, it's in that. I took a picture. I took a.
Check it. Before your presentation, come here, put it there and see whether it's okay. Read.
In 78 patients, it was uneventful. Only hardware symptoms were seen in 70 patients and complications in 52 patients. In hardware symptoms, when present, 45 patients underwent hardware removals and 25 patients retained. For complications, reoperated for 38 patients and no secondary surgeries for 14 patients. Conclusion, tension band wiring is non-inferior to plate fixation for Mayo 2A and 2B olecranon fractures in terms of functional outcome. Mayo.
Whenever in English A comes, it's spelled as A. Apex, not A.
Tension band wiring has shorter operative time, 64 minutes compared to plate fixation, which was 88 minutes. Plate fixation result in fewer hardware irritation and fewer secondary surgeries. Both techniques achieve excellent fracture healing and good functional results. Use of tension band wiring for simple fractures when minimizing cost and operative time is important. To prefer plate fixation in active patients or when reducing reoperation risk is a priority. Criticism, it is a multi-center design.
ChatGPT? Yeah, it's good, but yeah. Is it ChatGPT?
Yes.
Yeah.
You have to compare your version with the ChatGPT.
Yeah.
Yes, sir.
How much improvement you can make with ChatGPT? What is going to be your standard of criticism?
Yes.
Don't directly put into ChatGPT. That is how we learn. We also do that.
PPT, ChatGPT or your own?
No, sir.
Your own.
Multi-center design introduces heterogeneity in surgical technique and care protocols. It was done in 10 centers, and inclusion.
So it's a good thing or bad thing?
It's,
Heterogeneity.
it's good.
Good thing?
Multi-center.
Anybody?
Because the surgeons are
Now
different.
we have the name, so we can call the name out. Charan is here. I know Charan name without photo, but not there. OT. Haima is here? No. Yeah, go on. Heterogeneity. See, if we want to compare two treatments, they should be treated similar way. If one senior surgeon treats a fracture and a junior surgeon treats, difference will be there because the results are same. So comparability. Heterogeneity, that means heterogeneity. If it is treated by same surgeon, two procedures, then comparability. Ravi is here. Ravi, can you elaborate? You know. Okay.
Inclusion limited only isolated olecranon fractures, and findings are not generalizable to fracture dislocation or any complex injuries. And follow-up is capped up to 24 months only, so no long-term arthrosis or functional decline was assessed. And higher secondary surgery rate in tension band wearing group may affect patient satisfaction despite non-inferiority. And
The whole idea is to publish, easy to publish. They could publish. And the results need not be positive, isn't it? We both are equal.
yes, sir.
Both are equal, and we all know that tension band wearing, because of the voice, we have to take the removal of metal is more.
Secondary surgery.
Late also can
Problems.
because it is subcutaneous.
Yes.
That's why both groups, the incidence is very high.
Yes.
In Europe, they do not take implants out unless there is a good reason to take out. Unless there is a problem, they won't take it out. Because removal of implants, the complication rate is very high. So they don't take them out routinely. But here, 38% and 26 or 28% is very high.
Thank you.
Okay, good.